exactly that's what I'm just asking you. नहीं किया था शायद।
नहीं किया सर।
ओके बेटा, तो ये फेज ऑफ क्लिनिकल ट्रायल के लिए बेटा एक वीडियो, एक लॉन्ग वीडियो है जिसमें एक्सप्लेनेशन है, वेबिनार एक्सप्लेनेशन पॉइंट ऑफ फेज ऑफ क्लिनिकल ट्रायल, जो अब मैं आपको प्ले करूंगा। एट द सेम टाइम वी आई लाइक कीप ऑन एक्सप्लेनिंग द कंसेप्ट टू यू इन बिटवीन इन मॉडरेशन, जैसा आपको चाहिए वैसा। ठीक है बेटा, तो ये करते वक्त मैं आपको स्क्रीन वापस शेयर करता हूँ। ओके, तो ये स्क्रीन अभी जो शेयर किया था, दिस वाज इन कंटेक्स्ट टू व्हाट वी वेयर एंड वेयर वी वेयर। इसमें बेटा दो चीज़ें बचा हुआ है, 7 and 8 पॉइंट ऑफ 1.4, दैट इज ओनली थिंग विच इज लेफ्ट आउट इन द सेक्शन 1। ओके,
Yes,
so
sir.
let's first let's go to beta the video part. So I'm going to share the video section now with you. आप मुझे सिर्फ एक चीज़ और बताना बेटा कि आपको मैं म्यूट होने के बाद भी आपका वीडियो को साउंड आता है या नहीं आता है, वो मुझे कंफर्म करना बेटा। क्यों मालूम है? क्योंकि बैकग्राउंड नॉइस थोड़ा सा है आज, इसीलिए मेरा रिक्वेस्ट ये है, अगर वो वर्कआउट होता है, इफ माई म्यूटिंग डज नॉट अफेक्ट द वीडियो साउंड म्यूटिंग, देन इट विल फाइन बेटा। सो दैट्स व्हाट आई विल डू। ओके, अच्छा
Yes,
आपको स्क्रीन दिख रहा है बेटा?
हाँ सर दिख रहा है।
ओके, मैं अभी बेटा अपने आप को म्यूट करता हूँ, एंड आफ्टर अ मिनट आई विल आस्क यू इफ यू आर एबल टू हियर द पर्सन स्पीकिंग। ओके,
Yes, sir.
This out together. Basically, there's a lot to cover in something as simple as clinical trials. They really are simple. That's one of the beautiful things about them. And so basically, I'd like to put this in a little bit of context. And
so were you able to hear beta?
Yes, sir.
Yes, sir.
Okay, okay, that helps me. So background noise नहीं आएगा, आपको वीडियो को specifications आएगा बेटा। Okay, I'm playing it. I'm muting myself, but I'll unmute and I'll answer your questions and explanations, everything as it goes on. Thank you so much beta for confirming.
And so basically, if you consider what is the spectrum of evidence, why do we believe what we believe? And basically, studies can be sort of ranked as from the weakest to the strongest, and clearly the weakest are what are called ecologic studies. And ecologic studies are that people in the south of France drink a lot of wine, and people in the south of France tend not to die of heart disease. Gee, I bet it's because they drink a lot of wine in southern France. And the key of an ecologic study is I didn't measure anything on anybody. I measured outcomes for a group of people and exposures for a group of people, and then I guessed that they are associated. Sort of moving up the food chain, the next level is observational epidemiology, something dear to my heart. And within that, there's also sort of a ranking of food chain of studies. And I wish I had more time to talk about all of these, and I do hope they're covered in your experience. But sort of the weakest is a case control, where I get sick people and well people and look backwards to see what made them sick and well. The next level up is a cross-sectional design. You can think of that being a snapshot. I take a picture at one point in time and see who's sick and who's well and who's exposed and who's not exposed. There's no temporality in a case control study. The highest on the food chain of observational studies is the prospective cohort. And basically the idea here is I get a group of people who generally don't have the disease, and I measure a whole bunch of stuff, and then I wait patiently, sort of vulture-like, to see who develops disease and who doesn't get the disease, and then say, aha, it was the people who smoked who got lung cancer later. And so that's it. And then finally, is this what we're talking about today, the randomized clinical trial? It's always referred to as the gold standard evidence. And it's amazing how few people don't really understand why it's the gold standard evidence. Wanted to take a second and make sure you're cool with that. And so basically, in the 1990s, I'm old. In the 1990s, there were a boatload of beautifully done studies that clearly demonstrated hormone replacement was protective of heart disease and stroke in women. In fact, I stood at the podium of the Heart Epi meeting and put my arm around Trudy Bush, God rest her soul, and said, we can never mount the Women's Health Initiative because we all know for sure that hormone replacement protects women from heart disease. It is unethical to do this study. And then 3 clinical trials with many fewer patients than observational studies suggested hormone replacement was not only protective, in fact, it was harmful. You know, the entire field just dumped those epi studies and went with the clinical trials. It's now dogma that you know, hormone replacement's not cool. You know, how can that occur? Why do we accept the results of the RCTs over the results of those incredibly well done, beautifully done observational epi studies? And so the idea of this is an important topic for today, which is confounding. I want to make sure, by the way, at different points in my lectures, I always say, this is an important point. I'd like you to remember that. I'll say a bunch of stuff that must not be important because I don't say it then, but this is one of the things I'd like you to take home. This is one of the things so basically a confounder is I have some exposure, estrogen, and I'm interested in seeing if it's related to some outcome, heart disease. Okay, so that's the relationship I'm interested in. Okay, but I've got this other thing hanging around in the ether called a confounder, and it's for this is probably socioeconomic status. Probably socioeconomic status. And it turns out that rich white women took hormone replacement. I mean, you know, rich, and also rich white women don't have heart disease. Okay, and so instead, what we were fooled into thinking was that that, by the way, by the way, people define things differently in science. I'm sure you've noticed that. My definition of a confounder is anything that's associated with both the risk factor and the outcome. Okay, if you're a hardcore epidemiologist, there's a little phrase that is added that says, and it's not in the pathway. Okay, I'm not smart enough to know what's in the pathway and what's not in the pathway. And my example of that is always inflammation. You know, inflammation is causative probably of atherosclerosis. And by the way, atherosclerosis is an inflammatory process that increases inflammation. So the things are pointing at each other. Is it in the pathway or not? I don't have a clue. My definition is anything that's associated with both the risk factor and the outcome. And these can lead to false associations, and that's what happened here. Okay, and so in this case, rich white women are more likely to take hormone replacement, and rich white women are less likely to have heart disease. So it looks like hormone replacement protected you from heart disease. Okay, so how does randomization fix confounding? Well, with randomization, the high SES women and the low SES women were equally exposed to the risk factor. Okay, and so basically that leg of the 3-legged table is broken. Okay, and it doesn't matter that the confounder is still related to the outcome, because things cannot be a confounder unless they're related to both the exposure and the outcome. And randomization breaks that 3-legged table, and that's cool. That's cool. And remember this, that's the cool thing about randomization. Now, randomization is wonderful for many reasons. I wish I could talk more about it. But the single biggest reason is not only are high and low SES women equally exposed, but there's equal exposure for all risk factors. For all risk factors, even the ones we don't know about. It fixes the confounders for factors that you're not even aware of yet. It turns out observational epi, and I think I say this here. So I don't know if I say this, I might say this in a minute. I've forgotten what I'm doing next. But anyway, so the cool thing about randomization is that it does it for both the ones you know about and the ones you don't know about. And so why not do all randomized trial? And the reason for that is research is a process. You start out with ecologic studies, you move through randomization, and then finally at the end of the day, when it's really well understood, you do the trial to put the nails in the coffin. You don't start by doing a randomized clinical trial. They're really expensive. The CREST trial that was mentioned in the introduction is a $65 million study. and you don't frivolously do $69 million studies. And basically, they only address one question at a time. So if you think about it, that's a boatload of money to answer one question. And also, some things just can't be done with randomized clinical trial. We all believe seatbelts prevent deaths in cars. There's never been a randomized trial of seatbelts. Interestingly, the tobacco companies, I used to be from Winston-Salem, a town, the cigarettes were named for the town, not the town for the cigarettes, by the way. But anyway, and the tobacco companies are so cool. They come out and they say, there has never been a definitive evidence that cigarettes cause lung cancer. And I agree 100% with them. Absolutely a true statement, okay? To do that, you would need to randomize children to smoke and not smoke, and then follow them forward and wait for who develops lung cancer. And then we would have the proof that cigarettes cause lung cancer. And the people who buy into this, I don't believe that if it's not a clinical trial, should be comfortable with the tobacco company's claim, correct claim, that there's no definitive evidence of a link, because they're right, okay? But anyway, so a lot of things can't be done. Parachutes, never been a randomized trial of parachutes. It's just not going to get done. Okay, so in terms of the big picture of trials, and all this is just leading in, I'm talking about phase 3 trials, and it's important to put those in the context of the clinical trials process. And so the first trial is called a phase 1 trial. By the way, this phase 1, 2, 3, 4, different definitions by different people, so watch out. These are my definitions, and most people agree with me. Other people have different definitions. A phase 1 trial is simply, is the drug tolerable? The first in humans attempts. If I give this to somebody, do they die on the spot? Typically done, particularly in cancer trials, in very sick people, just to make sure the drug is cool. Okay, the next is where we begin to get different definitions. A phase 2 trial, early efficacy trials. And they're usually divided into what's called phase 2A and 2B. A phase 2A trial is a safety dosing study, usually giving the drug and looking at the levels of the drug in the serum. Are we delivering? Because if you think about it, where we're doing is moving from giving drugs to rats to giving drugs to people. And if you start trying to guess, well, rats about that big and they use this much drug and the human's about this big, we're just going to multiply the height of the rat by the height of the person, which is pretty much what you do to get the dosing for the person, okay? Might guess wrong. So the first level is safety dosing. The second is early efficacy assessments. That's phase 2B, okay? Early efficacy assessments look at surrogate outcomes. Okay, so I'm not going to look to see if we prevent stroke. I'm going to look if we prevent stroke on a CT scan, okay, which is a subclinical stroke. So I'm going to look to see if it stops progression of carotid atherosclerosis. Because if a phase 2 trial had the same outcome as a phase 3 trial, it would be called a phase 3 trial, okay? Then finally, what we're talking about today is the pivotal trial. Does safety, efficacy, meets regulatory requirements? Importantly, it doesn't answer all the questions all the time. By the way, y'all should be asking questions too, so stop me. Remember, I wanted you to stop me. Anyway, so next is the post-marketing assessments, the further safety trials. And so why don't we nail down safety in the phase 3? Well, the phase 3 trial is powered to go after efficacy. Does the thing work? It's not powered to go after safety. Is this thing safe to use? So the example of that, perfect example, is Vioxx. Okay, Vioxx, incredibly efficacious, stops pain, works great, okay, but it increases heart disease risk.
So guys, here is the big picture where you see what are the various phases of the trials which we are supposed to know, or what are the phases, the different phases of clinical trials which you are supposed to know. So there are phase 1, phase 2, phase 3 and phase 4. Then the phase 1 is toleration or safety studies. Phase 2 is early efficacy, subdivided into 2 parts. 2A is for safety dose finding, 2B is for early efficacy assessment, which is called surrogate outcomes. Phase 3 is called as the pivotal trial assessment, safety, efficacy, and regulatory requirement. This is the major one. This is the one which has the end result, which will give us permission to go ahead and do NDA, new drug application, find out for it. Then after the application has been filed and permission has been granted, then there is something called as post-marketing surveillance or post-marketing assessments, PMS studies. So these are called as phase 4 studies, additional indication, routes of administration, etc. So these are the big picture of various phases of the trials. So guys, I would suggest you to have a screenshot of this part beta, because this is the one which is the answer direct to your question, which is what are the various phases of clinical trials. Okay, please let me know once you have done the screenshot of it.
Yes, sir.
Done? Okay, beta. So I'm playing it further. Please remember, this is the one which will be the one which is elaborated further, and this is the gist which you are supposed to write down whenever you have these sort of information regarding asked out. What are the various phases of the trials? So the phases of trials are phase 1, phase 2, phase 3, phase 4. Okay, and then phase 2 is subdivided into 2 subparts, and what the elaboration is all about. I'll explain as it goes on, and as it required in between, I'll stop and explain the concepts to you better. If there is any question, you can ask me. All right? Okay, playing further now.
But the heart disease risk is still so rare that the study's not big enough to see it in the phase 3 trial. And so we have to do this post-marketing assessments of safety afterwards. And so this is really all a process, but for today, we're just focusing on the phase 3 trial. Everybody cool? Yes, ma'am. Thank you.
In phase 4 trials, when you say post-marketing, is that like the FDA gives like, okay, we start seeing commercials for it and there's still trials going
Yeah,
on?
exactly. The question was, is this something basically required by the FDA? And so exactly, that's precisely what happens. The FDA approves the drug, but says, oh, we're a little bit worried about heart attacks with your Vioxx. And we're going to require you to collect data systematically to make sure that people aren't dropping dead while their knees feel great. Okay? And so basically, usually they're required by the FDA. The FDA is incredibly, phenomenally powerful. Someday you will have an FDA audit and you will be impressed by how powerful your FDA is. It's an amazing process. Okay, so here is the outline for today. This is all we need to cover today. Okay, and this is why it's going to seem like we're hopping around a whole lot. Okay, and when I teach this as a course, each one of those brown things is a separate lecture. And so what we're going to do is 3 slides summarizing a whole bunch of a semester-long lectures. Okay, so don't get too confused. Try to bear with me. We're going to start off with the ethics of clinical trial. It's really hard. I mean, if you think about it, all a clinical trial is human experimentation. That's all it is. Okay, we're randomizing people to different treatments. The barrier between us and the Nazis is phenomenally small. I mean, it is phenomenal. I mean, stop and think. If you're a clinician, most of you, I assume, are clinicians. When you're asking somebody to be in a trial, that is a huge ask. I mean, that's not a small thing. And the key to it is equipoise. And a lot of people don't understand equipoise. I mean, are any of y'all surgeons in the group? Oh, I get to insult surgeons. They're online. Okay, I'm sorry. Please forgive me. I've never met a surgeon who's an equipoise. I mean, these guys and gals know with certainty that cutting you open is going to make you better. I mean, they don't think that. And by the way, I want them to think that. I mean, that's not a bad thing. That's a good thing. If somebody is cutting me open, I want him or her to have a very deep belief that they've got a good reason to do it. Okay? Equipoise is not whether I doubt it, it's whether we doubt it. Whether, in your opinion, there's not a collective body of evidence that we share and agree on that this treatment is good. Equipoise is a community statement, not an individual statement. And you can remember that, again, because surgeons are never at equipoise. They're never at equipoise. Okay, again, clinical community versus, oh, by the way, I love how we do trials and how the Europe does trials. They have a different principle. They deal with what's called the uncertainty principle. And the uncertainty principle, if you do a European trial or you do trials with Europeans, they put people in studies when the individual PI is uncertain what study is best, what treatment is best. Okay, fundamentally different approach. You know, in the US, we get all over sites who don't put eligible people in studies because we worry about whether it's generalizable to the entire group. And so if we find out that you're not putting somebody in the study who's eligible, we come down on you like a ton of bricks. That's different in Europe. They say, oh, I wasn't sure. I was pretty sure, you know, this treatment would help the person. I'm not going to put them in. So they're, you know, that's not a subtle difference. Okay, and that brings up the whole topic of informed consent. And how many of y'all have consented patients for studies? So everybody has. Do you think they understood what you were saying? Tell the truth. I mean, I mean, here's the cynical comment for today. Informed consent is to protect the university. It is not to protect the patient. I mean, regards, which I was brought up at the beginning of this, the most invasive thing we do is draw blood. That's the worst thing we do to people. Our informed consent is 8 pages long. Can you believe? I mean, that's amazing. The worst thing we do is stick a needle in the arm. Anyway, and so so stop and think. I think we do have a duty to have people understand because what we're asking them to do is, as I said, a huge ask. But in general, that's going to take more than going over the informed consent document. I think it really will require a discussion with these people that goes quite beyond that. So the next topic, if you look at that outline, was the different type of hypotheses. Okay, and so basically, what I want to do is have a hypothesis that's clear, quantifiable, simple, singular. I'm doing one thing in a clinical trial. And what it does is give the who, what, and when of the study. This is the CREST primary hypothesis, and it's to contrast the relative efficacy of stenting and endarterectomy, that's the treatment, and preventing the stroke, myocardial death and during a 30-day procedural period, and stroke afterwards. That's the what and the when. And then in patients with symptomatic or asymptomatic extracranial stenosis, that's the who. So when you're thinking about writing a hypothesis, make sure you've got the who, what, and when are all there. And it's amazing when you read these from even big trials, a lot of times, I mean, you should be able to give your hypothesis statement to somebody and have them pretty much understand what you're doing. I mean, they won't understand the details, but they'll get it the 30,000 foot view. Okay, now let's get into something that is a little bit more complex, which is, and people talk about superiority trials and inferiority or equivalence trials. And this is sort of an important thing and a different way of thinking. So I'd like to take a few minutes and just go over those and make sure that you're cool with this. And so basically the idea of a superiority trial is to address if 2 treatments are the same. So what, by the way, in all of statistical testing, whatever you want to prove is true, you assume is false. Okay, then you go out and collect data and try to prove how silly you were in saying that it was false. That's the whole idea of statistical testing. So if you're doing a superiority trial and I'm trying to prove 2 things are different, I assume that they're the same. I assume that whatever I'm trying to prove is not true. I conduct an experiment to prove how different they are. And, you know, basically what I have is, suppose there's a new treatment and an old treatment. And I want to show the new treatment is as good, really not worse than the old treatment. That's a whole different way of thinking. That's a lot different than proving that they're the same. If I want to show that I'm setting out to prove they're as good. So let's say the new treatment is less invasive and costs less. Okay, so I don't need to prove that it's better. I only have to prove that it's as good. Because if I'll save money and I won't have to do surgery, for example. Yes, ma'am.
So this is why it's confused me with drugs. If there is a new drug and the randomized trial at the end compares that drug to the standard of care, and there is no difference, but the drug, for whatever reason, costs less, the FDA can then still approve it, even though there's no benefit to the patient.
This is a great question, and this is exactly what I'm talking about. This is what.
So guys, this is about a wonderful discussion going on. This is about something called hypothesis. So whether you like it or not, you will not be able to run away or drop statistics, because biostatistics is going to follow you all the way in all the sciences which you do. So what exactly is hypothesis? Anyone? Any thoughts on it, beta? Anyone of you who wants to answer? What do you think is hypothesis, beta?
So any theoretical possibilities?
Okay. All right. So we have only Ashita and Rinku. Yes, beta. So that's one point which you said. Okay. What do you think, beta? Other way? Hello. Any other thoughts which you have? Yes, Ashita. Go ahead. Yeah, but Ashita, you can go ahead, please. You want to say something?
No, sir, the same thing.
Okay, same thing. All right. What about you, Rinku, beta? What is your thought process?
It is an idea that propose something tested. Hello.
Okay, I'm hearing, but I'm there. I'm hearing. Yes. Okay, so what we have here is with our two perspectives. Number one, hypothesis. When we say it is hypo, means it's an imaginary word. It's not actually being there. You are assuming things. Okay, so assumption is one thing which you are putting forward to, and now you want to make a science in that. The assumption has to be right. So what you are saying is, in simple terms, you are asking a question. Okay, the question has to be right question. So what is the question which all about? The question is, okay, is this chemical substance which you are saying as the chemical substance, which you think will be a drug in later part, able to do what you think it does? That means, for example, if you are thinking about an antibiotic, is the antibiotic gonna kill the pathogen or the bacteria which you are targeting? That's the question which you're asking. Okay. Second part would be, when you're asking this question, so you would also know that maybe there is another compound which is already available in the market, which is better than this. Okay. So you would want to know, as compared to that, how good is this compound of yours? So these are two questions which will come down to you. Correct. So answering these two questions is what you have the hypothesis being there. Okay, so you are trying to have the right question asked, and you have to answer these questions with statistical significance. That is what is the basis or fundamental behind doing a hypothesis. So you can see one of the ladies in the webinar section, as it is going on in Huggins, had asked this question कि supposingly बेटा एक मेडिसिन आपने बनाया, एक मेडिसिन जो आपके लिए है फंक्शनिंग में है, वो मेडिसिन आपने बनाया और उसको टेस्ट किया ट्रायल्स में, तो पता चला कि वो सेफ है, इफेक्टिव है, लेकिन जो एग्जिस्टिंग मेडिसिन है उसके बराबर ही इफेक्टिव है। तो अभी नेक्स्ट क्वेश्चन ये उठता है कि उसने ये पूछा कि अब आप उसको परमिशन दोगे कि नहीं दोगे भाई मार्केट करने के लिए। ओके, तो उसमें उसने एक पॉइंट डाल दिया। ये पॉइंट है कि वो जो मेडिसिन जो अभी जो नया आपने ढूंढा है, ओके, वो एग्जिस्टेंट मेडिसिन से सस्ता रहेगा, इकोनॉमिकल रहेगा। तो अगर वो सस्ता रहेगा और उतना ही इफेक्टिव है जितना वो बाकी का मेडिसिन है, तो क्या आप परमिशन दोगे या नहीं दोगे? आंसर इज ऑब्वियसली यस, क्योंकि आपका एफडीए यही चाहता है कि भाई आपके पेशेंट्स की हेल्थ इज फर्स्ट। तो वो चाहता है कि भाई ऐसा कोई और मेडिसिन आए जो इकोनॉमिकल हो, सेम एफिकेसी और सेफ्टी वाला हो, तो इट विल बी अ वेलकम बाय द एफडीए। सो दैट इज व्हाट इज बीइंग थॉट अबाउट। ओके बेटा, इज इट क्लियर गाइस? आशिका, रिंको, प्रीति बेटा, गुड। बाकी फ्रेंड्स थोड़ा रेस्ट करने गए? ओके, नो प्रॉब्लम बेटा, दैट्स फाइन, चलेगा। ओके, विल कंटिन्यू अहेड।
There, I tell you, let me get to the end of this. So the question was, if you do a trial and there's no difference, can the FDA still approve it and claim that it's as good? The answer to that is, it depends on what their hypothesis was. Okay, and that's what the difference that I'm trying to bring up here is. And so basically, and this is important, if you're doing a superiority trial, trying to prove two things are different, I assume that they're the same. And the trial, I hate this word, it's a negative trial. You don't see a difference. There are two reasons why it could be the same. Okay. The first reason is it's the same. Okay, it really is the same. And the second reason is I didn't have enough people in my study to see whatever difference was really there. Okay. There's no way on earth you can know which one of those is happening. Once you do a superiority trial, and there's no difference, you can never know which one of those two things happen. It's impossible. Okay? So basically, you cannot tell which is true. One never, by the way, in all of statistical testing, this is one of those take-home points. One never accepts the null hypothesis. Okay? One only fails to reject it. Let me say that again, because that one's important. In all of statistical testing, you never accept the null hypothesis. You would never say that they're the same. What you would say is that, by the way, this implies that traditional studies cannot be used to show that the new product is as good as the old. So if it comes out negative, what you say, and this is on the next slide, you end up with sort of a kiss your sister kind of statement. There's not sufficient evidence in these data to show that the two groups are different. Intentionally a double negative statement. Let me say that one again. There's not sufficient evidence in these data to show that the two groups are different. Okay, that's a whole lot different than saying they're the same.
Can I ask you a question about that?
Yeah,
slide?
sure.
So you said you can't tell the difference between if there's no difference or the study size is the sample size isn't large enough. What if you have a very large sample size?
Well, it's still not large enough. By the way, there are no two things in nature that are the same. Okay, the intelligence of men and women is not the same. A radical statement, get me in trouble. I don't know which one's smarter, but the chance that there two things are exactly precisely the same is impossible, statistically impossible. There is nobody 5 feet tall in the world. Okay, we just haven't measured people well enough. If we keep measuring them with sufficient precision, we will find out this person is either a smidgen above or a smidgen below 5 feet. There's nobody 5 feet tall. Okay, the philosophical part of this is that means the null hypothesis is always false. The two groups are always different. Okay, I just can't tell in what direction or how big it is. And so that all that is to answer, if the sample size was big enough, I would have found the difference that I know exists with certainty. but that's sort of philosophical, statistical philosophy instead of anything else. Okay, so basically, so the answer is, if I want to prove two things are the same or one is as good, what I have to do is to change the form of my hypothesis. I have to use a different form of my hypothesis. Okay, and so instead, and this was work by black welders, frequently also called black welder trials or superiority or non-inferiority trials. And so the new hypothesis is the new treatment is worse than the old. That is my null hypothesis. And my alternative hypothesis is now the new treatment is as good or better than my old. I've turned the hypothesis inside out. I want to leave this up here for a minute because I do see some wrinkled brows. And does everybody understand that what I'm doing is playing a game with the hypothesis? I'm changing to what I want to prove is true, I assume is false. If I want to prove it's as good, well, I'm going to assume that's not true. That means that the new treatment is worse than the old. And now I'm set up to prove it is as good or better than the old. Pretty cool, huh? Cool idea. Really backwards thinking, okay? And so if we reject the null hypothesis, then we can make a definitive statement that the new treatment is as good or better, because I can accept my alternative hypothesis in statistical testing. I just can't accept my null hypothesis. Everybody cool? Okay, so simple in concept. Non-inferiority, sometimes referred to as equivalency, sometimes referred to as black welder trials. There is a slight difference between those. Don't worry about it. At the level you're at, just think of them being the same. Okay, and so then basically, regardless of the form of the hypothesis, a study provides an estimate of the difference between the treatments. I'm going to do a trial and estimate how different the two treatments are. I'm going to calculate 95% confidence bounds around those estimates. Here's a cool thing. There's a link between hypothesis testing and estimation. And basically, if whatever I hypothesize the difference is inside of the confidence limits, I will always fail to reject my null hypothesis. Alternatively, if whatever I'm assuming is outside of the 95% confidence limits, I'll always reject. And I'll show you what I mean by this. Right now, I see more crinkled brows here, but you'll get this in a minute. So basically, so what I'm going to do is a little bit of background. Let's say I have two treatments or products. I have an established treatment and a new treatment. I have a dichotomous outcome, a yes-no outcome. And I just want to calculate the percent of events in the established treatment. I'm going to call that pi sub 0. I don't do a lot of math. Trust me, don't panic if you're a math phobe. Then the number of events in the alternative treatment, pi n, and in general, which treatment is best. So traditional hypothesis testing, superiority testing, traditional, okay? The null hypothesis, no difference between the treatment groups. So I'm going to say that pi 0 is equal to pi n. Okay, alternative hypothesis is the groups are different. Okay, that pi 0 is not equal to pi n. This is not hard, by the way. Even I can do this. This is easy. Okay, so basically, if you do that, then what I have here is a bar, and on this side of it, I'm saying the old treatment is better. On that side, I'm saying the new treatment is better. So what I do is I calculate the difference in those two proportions. And I can put a little bar on my graph and say, there it is. Okay. And then I can calculate 95% confidence bounds around that. Draw those. Okay. Now, if that happens, if the 95% confidence limits do not include 0, then the two groups are different. That's how simple traditional testing is. So basically, if you think about it, there are three things that can happen if you do a traditional superiority trial. Okay. You can claim that the new treatment is better than the old. You can claim that there's no difference between the two treatments, or you can claim the old treatment is better. Okay, those are the two things. And by the way, I just fundamentally messed up. I said you can claim the two groups are the same. I should have said that was a slip and a bad one in this class. Okay, what should I have said? No evidence in these data that the two groups are different. And by the way, going back to your sample size question, basically, if you increase the sample size, you keep making those confidence bounds itsy-bitsier. And if I keep on making them itsy-bitsier, I will always find differences. We're going to come to how itsy-bitsy you want them as part of this lecture, by the way. Okay, so what are the advantages and disadvantages of a traditional study? The advantage is I can make a definitive statement that one treatment is better or worse. Okay? The disadvantage is if there's not an evidence of a difference, I cannot say that the two treatments are the same. I should not do that. Okay? The null hypothesis is not, by the way, in a lecture, when anybody gives a lecture and they say the same thing like 20 times, that's because they think it's really important. Okay? So the null hypothesis is never accepted. It's simply a case where you fail to reject it and you end up making a statement there's not sufficient evidence in these data to establish that a difference exists. Okay? And but the manufacturer sometimes only wants to say that the new treatment is as good. And if you do that, you do an equivalency analysis. Same picture. The goal here is to make a definitive statement that the new treatment is as good or better than the old. The null hypothesis is now the new treatment is worse than the old treatment. And here's the twist, plus a fudge factor. Okay, plus a fudge factor. And so basically what you say is that pi sub 0 plus the fudge factor is less than the new treatment. Okay. And the alternative is that the new treatment is as good or better than the old treatment plus the cushion, okay, which is the pi 0 plus the fudge factor is bigger than delta. Yeah. Okay. And so basically, therefore, the definition is as good really means that it's within the cushion. Every superiority trial you will ever read has a fudge factor. When you're reading these, you should be, by the way, in the discussion, if it comes out as a positive inferiority study, they say the new treatment is as good or better than the old. What they really should say is the new treatment is as good or better than the old, and I define as good as being within 2%. Okay? Okay, that fudge factor is always there. If you're reading a superiority, non-inferiority trial, always be acutely aware of that fudge factor, how big that fudge factor is, and whether you think being within that fudge factor means it's the same.
So, but I'm not expecting you to know the entire stats of it. Okay, but what I expect you to know is there is an equivalence analysis. What exactly is an equivalence analysis is that you are comparing between two facts. Okay, whether the definitive statement that new treatment is as good or better than the old is the one which you are trying to answer. So null hypothesis will say a new treatment is worse than the old treatment, and then you will prove it otherwise. So an alternative hypothesis will say new treatment is as good or better than the old treatment, and prove it. So these are two modalities of how you would want to prove a particular point in terms of whether it is efficient or not. And this is what is basically the fundamental crux behind doing any of the clinical trials. Okay, beta. So you have to just remember this much, because when you guys go ahead and do any specialized courses in clinical research, there you would have the elaborative details of how this is going to be interfered and inferred out, and how you would be applying these fundamentals in types of trial perspective. For example, like you may be looking into something called adaptive trials, you may be looking into parallel studies, you may be looking into the single straight studies, quadrant studies. So when we look into those details, that's the time when you would be having the elaborations required. Okay guys, so till here beta, any questions from you? Ashita, Preeti,
No, sir.
Rinku, any questions from you, beta? Okay. I'm still playing it a little bit more. Okay, I know you guys, only three of you are being there. That's fine, no problem, beta. The reason this is being there is to just get you familiarized with the concept at the level which is required in the industry, beta. Okay, so it's not like that. Okay, I'm just playing and I'm just waiting around the time. No, it's required because you will understand the crisp context behind it. So listen to it, no problem. I'm anyway here to explain beta. Okay, so I'm continuing playing it out now.
So testing between groups in the equivalency approach, what I have is the new treatment, there's no difference. Here's my fudge factor. And I can calculate the difference in the proportions. There it is. And then I calculate, and here's the other difference in superiority testing, a one-sided confidence bound. And so what I'm going to do is calculate a one-sided 95% confidence bound around that estimate. And it starts there, it goes up to infinity in that direction. Okay. And if you do this, two things can happen. Oh, by the way, if the 95%, the bottom end of this 95% confidence bound right there, that blue thing, does not include delta, okay, then the new treatment is as good or better than the old. Because really, if you think about what we're saying, let's see if this works again. Okay, really what you're saying is that I'm pretty sure the treatment difference is in that blue line. And if this is what I declare as no difference, if it's above that, then it must be as good or better than the old. And that is the whole idea of superiority testing. Is everybody, I see some sort of confused faces. So is everybody okay? Any questions or anything? This isn't hard. Don't make this hard. Make this easy. Okay, so the outcomes in equivalency testing, only two things can happen. You're either going to say the new treatment is as good or better than the old treatment, or you'll say there's not evidence that the new treatment is as good or better than the old treatment. Because in this case, the bottom of this confidence bound includes the delta.
Is delta the fudge factor?
Delta is the fudge factor. In carotid endarterectomy trials, your FDA has pretty much defined the same as being within 2%. And so if I'll ask you, if I was your patient and you were going to do a study on me and I had a 10% chance of dying on the table versus a 8% chance of dying on the table, would you consider that the same? Okay. Now, this delta is tightly tied to the sample size delta that you're talking about, which is defined as a clinically significant difference. We're going to come back and talk about this later. And basically, they're the exact same concept. Okay. In other words, if you're designing a superiority trial, you have to say, I'm designing this trial and I'm interested in detecting differences bigger than 2%. Okay.
How is the delta determined? Is it based on pilot data or?
Okay, so the question was, how is the delta determined? Was it based on pilot data? It's interesting. If you think about it, if you're doing a pilot study to estimate what the difference is, by definition, you don't have enough people in your study to well estimate what the difference is. If you did, you wouldn't be calling it a pilot study, you'd be calling it the study. Okay, and so the one place that you really shouldn't get the difference is from pilot data. Because you just said, I have an unreliable study that gives me crappy estimates. I think I'll use those to design the big study. And that's really, I mean, you need to say these things out loud to really get into the spirit of the junk you're doing. Okay, okay. So most of the time where the delta comes from is, there are two places, a good place and a bad place. The good place it comes from is just discussions with clinicians. How big of a difference does it take for you to change your practice? And the second, the bad place it comes from is if I say this is 3%, I can do my study with 200 people. And if I say it's 2%, I'm going to need 800 people. I think the difference is 3%. Okay? Because I can't afford to do the study at 2%. Sorry. Okay, so anyway, the advantages of the equivalence approach, I can convince me for a definitive statement, the new treatment is as good or better. Usually that's all a person wants. And I'll stop there and see if you have any questions because I'm getting ready to change the topic. Okay. One-sided versus two-sided hypotheses. Okay, a one-sided assume that there's a new and old treatment, and the outcome is the proportion of people with events. Okay. And so basically a two-sided hypothesis is I assume that they're the same versus they're different. They're different can mean one is bigger than the other or the other is bigger than the other one. A one-sided hypothesis is that the new treatment is basically as equal to or bigger than the other versus it's less than. Okay. When does logic suggest we should use a one-sided hypothesis? Basically assume that the new treatment would not be used unless it's clearly better than the old. Okay. For example, assume the new treatment is surgery, old treatment is aspirin. If unless surgery is better than this, I don't really need to prove that medicine is better than surgery. I need to prove surgery is better than medicine. This is what happened in the asymptomatic carotid atherosclerosis study in my academic childhood. Basically, at the beginning of the study, there was a 2020 story about how many needless deaths there were with endarterectomy. Surely surgery would not be used unless it can be proven to be better. So a one-sided hypothesis seems logical. Why would you use a one-sided hypothesis? Well, restricting the alternative allows more power, statistical power. Basically, assume that you want to see that one group is 25% and be reduced to 20%. If I do this study with a two-sided hypothesis, I need to have 1,000 people. If I do it with a one-sided hypothesis, I only need to have 800 people. That's good. If I'm not interested in increased risk from surgery, then basically there's a 21% reduction in the number of people exposed. Okay, so when should you use a one-sided hypothesis? Never. Okay, you never do it. You never do it. Okay, go find one in the literature. Go find a paper that has a one-sided hypothesis in the literature. I dare you. Why not? Well, basically, you're providing valuable proof. A one-sided hypothesis is used. You cannot definitively say surgery was inferior. Okay, in that case, it's difficult to discourage the procedure unless it's proven harmful. Okay. Again, going back to my dear, by the way, I only work with surgeons. I love surgeons. Don't get me wrong. My closest colleagues are all surgeons, but they will not quit doing something unless you prove it's bad. Okay. Okay. One-sided hypothesis also smells bad. If you use one, it's really hard to get your data published. Any questions? By the way, there's a lot of opinion in my lectures in case you don't get the sense of that. So we've done the hypothesis. Now how about eligibility? Who do I put into my trial? Who do I want in my study? Okay. So basically, who do you want in your randomized trial? Well, there's a great need for homogeneity of my patient population. If my patient population has divergent or weird people in it, okay, it introduces noise in the system, okay? And it can really distort the outcomes of the majority. A lot of times in our study, we don't put stroke patients in our trials that are under 45 years old because people under 45 have strokes for fundamentally different reasons than people over 45. Could be drugs play a bigger role in young people, could be congenital conditions play a bigger role. It's not that atherosclerotic process that we're trying to fight. Okay. So basically, the restriction of the population reduces noise and allows me to do my study in a smaller sample size. I don't know if y'all have ever heard of the Mr. Fit study. I won't go there. Let me skip that. I'm running behind schedule. But anyway, having a homogeneous population makes it so I can do it with a smaller number of people. Restricting the population to a homogeneous group is good. Alternatively, at the end of my study, I want to be able to generalize my results. Okay? And basically, at the end of the study, it's important to only apply the findings to the people who are like the people in the study. Okay, if I do a study in men, I can't generalize those findings to women, okay? So basically, it's questionable to whether or not the generalized studies can be generalized to those excluded from the study. And so basically, having a broad inclusion criteria that's welcoming to all is really a good thing. Okay? And obviously, these two things are perfectly and diametrically opposed. Okay? You want a homogeneous generalizable population is the answer to your question. Okay? So what's the correct answer? And the answer is there is no correct answer.
So guys, this is the requirement what you require in randomized clinical trial बेटा. तो एक randomized clinical trial मतलब randomization. Randomization, are you aware of it? Have you heard the word randomization?
Yes, sir.
Sorry Ashita, but I couldn't understand it clearly. Can you repeat it please?
Yes, sir, I've heard that word.
Okay, tell me beta. For example, suppose you are doing an animal study. Okay, animal study is an easy way to do. For example, आपके पास say rats हैं, mice या rats है, जो भी आप बोलना चाहो. आपके पास somewhere around 20 mice है और 20 mice को आपको दो ग्रुप में डिवाइड करना है. ओके, और दोनों ग्रुप में डिवाइड करते हुए बिल्कुल बायस नहीं होना चाहिए. अब उसे कैसे डिवाइड करोगे बेटा? आपके पास एक बड़ा केज है जिसमें 20 माइस है और आपके पास छोटे दो केज हैं जिसमें 10-10 माइस डालने का कैपेबिलिटी है, और आपको बोला गया है कि आप उन्हें बिना बायस के दो ग्रुप में डिवाइड करो. कैसे करोगे?
So बड़ा केस में 20 माइस है एंड छोटा केस.
हाँ, छोटा केज में बेटा 10-10 डालना है आपको. दो केजेस आपके पास.
So 10 और 10.
उठा के डाल दोगे?
मतलब अगर
है ना, कैसे कैसे पकड़ के उठा के डाल दोगे? चलेगा? ऐसा चलेगा?
नहीं.
फिर क्या करोगे? अच्छी बात है, मैं आपको बताता हूँ बेटा. हम लोग अगर पकड़ के डाल देते, सपोज आपने पिंजरा खोला और पकड़ने की कोशिश किया माइस को, तो दो कंडीशन हो सकता है. या तो बहुत क्यूरियस सबसे एक्टिव माइस आपके पास पहले आएंगे, फिर आप वो देखने के लिए कि भाई आप आए क्यों, मतलब आपका उंगली क्यों आ रहा दिख रहा है उसको, या खाना लाया वैसा करके, तो आप उसे पकड़ के पहले डाल दोगे. दूसरा ऐसा हो सकता है कि सबसे डल माइस जो मतलब भाग ही नहीं पा रहा है, वो वही बैठा हुआ है, उसको आपने पहले पकड़ लिया. दोनों ही केस में आपने बायस किया, मतलब यू आर जस्ट इंट्रोड्यूसिंग ए बायस, क्योंकि आप हो सकता है बहुत एक्टिव एक ग्रुप में जाएगा या बहुत डल एक ग्रुप में जाएगा. तो इसको करने का तरीका क्या रहेगा? आप क्या करोगे, वो 20 माइस जो है, 20 माइस के पैर पे, पॉ पे, पॉ बोलते हैं ना, PAW, पॉ पे लेबल लगा लोगे. एक लेबल मतलब मेटल का लेबलिंग मिलता है 1 2 3 4 5 6 7 20 तक. ठीक है, फिर आप क्या करोगे, आप 20 चिट्स बनाओगे. 20 चिट्स बनाने के बाद आप रिंकू को बोलोगे भाई उसमें से कोई भी 10 चिट उठा ले. तो रिंकू उसमें से 10 रैंडम चिट्स उठाती है. फॉर एग्जाम्पल रिंकू ने उठाया 1 3 9 17 15 समथिंग समथिंग ऐसे नंबर्स निकले. तो वो 10 चिट थे और जो बचे हुए 10 चिट हैं. अब ये तो आपने देखा नहीं भाई इधर 10 चिट कैसे रिंकू ने उठाया और आपने कैसे स्प्रेड अप किया. अब आप क्या करो, वो जो नंबर्स आए हैं वो नंबर के बंदे, जो कि 10 चिट रिंकू ने जो उठाया उसमें जो 10 नंबर्स हैं, वो नंबर 10 जो नंबर्स हैं वो 10 नंबर लेबल्ड वाले, पॉ में लेबल्ड वाले माइस को उठा के एक बंच में डालोगे और रिमेनिंग वालों को दूसरे बंच में डालोगे. तो आपने इक्वली दो ग्रुप्स बना लिए. तो इस प्रोसेस में आपने कोई भी बायस नहीं किया, यानी कोई भी चांस अपने अपनी तरफ से कुछ भी एड अप नहीं किया, रैंडमली हुआ. तो ये जो प्रोसेस हुआ, इस प्रोसेस को हम लोग बोलते हैं रैंडमाइजेशन. इज इट क्लियर बेटा?
Yes, sir.
अशिता, रिंकू, प्रीति बेटा,
Yes,
इज
sir.
इट क्लियर?
Yes, sir.
ओके, फाइल, गुड, फैंटास्टिक बेटा। तो क्लिनिकल ट्रायल में अब पेशेंट्स के साथ जब आप ट्रायल कर रहे हो उस वक्त भी अगर आप ऐसे ही मेथड यूज करोगे तो इट इज कॉल्ड एज रैंडमाइज्ड क्लिनिकल ट्रायल। तो पेशेंट के साथ करते वक्त हम लोग पेशेंट्स को नाम से नहीं जानते हैं, वी हैव अ एट्रीब्यूटेड नंबर, पेशेंट का एक नंबर रहता है, तो वो नंबर को या तो आप कंप्यूटेशन मेथड से कर सकते हैं या फिर ऐसा जैसे चिट वाले मेथड से कर सकते हैं। Whatever method we use, this is the method which is called as the randomized, and this is called as randomized clinical trial. तो randomized clinical trial में होने वाले significant phenomenon, okay, homogeneity and generalizability, ये दो patterns है जो दिखाई देता है, and that is the one which has been explained here, beta. So I'll suggest you, since you now know what is randomized clinical trial and what are the two aspects of it, homogeneity and generalizability, एक स्क्रीनशॉट ले लो बेटा, बिकॉज दिस इज वन इंस्ट्रूमेंटल पॉइंट विच इज वेरी इंपॉर्टेंट फॉर यू टू रिमेंबर। ओके, आप ले लोगे स्क्रीनशॉट तो मुझे बता देना प्लीज, देन आई कैन प्ले फॉरदर।
Yes, sir, it's done.
Okay, thank you so much for confirming. So I'm playing it further, beta. So the terms are homogeneity, divergent subgroup of patients, weird patients can't distort anything जो भी आप बोलोगे, generalizability. At the end of the study, it will be important to apply findings to the broad population patients which have been randomly selected, called randomized clinical trial.
Okay, it's a real judgment thing, and when you're reading trials, stop and think about who did they put in this study. Can this be generalized to my patients? Can I use these results? Yes, ma'am.
So when you were discussing the trial with the estrogen and the Women's Health Initiative in the beginning, they obviously had a problem when they were designing all of those observational studies, or I guess picking patients for those observational studies, or was there really nothing they could have done in the observational
Okay,
studies?
so the question is, going back to the estrogen trial, was that a matter of inclusion criteria and including the right kind of people in the study? It turns out that observational epi and in clinical trials always give the exact, precise, identical answer, always, as long as two things are true. Number one, you understand what all the risk factors are, and number two, you've measured them perfectly. Okay, the measuring them perfectly. So if I talk about socioeconomic status, how do I measure socioeconomic status? Well, by the way, the people doing the observational epi studies understood this. They tried to co-theory for socioeconomic status. They tried to fix this problem. How do we measure socioeconomic status? By far, the most common way is income and education. Okay, I have income and education. People make a lot of money. They're high socioeconomic status. I live in Talladega County. Okay, there's a racetrack over there. And there are people who make a lot of money around that racetrack. And when you meet them, you're not impressed with the underlying gestalt of their high socioeconomic status. We all know people who make a lot of money and they're not, this sounds horrible, but it's just hard to do a discussion with them. And income is not that measure. And I mean, and the world is filled with educated derelicts. I mean, we all know very educated people. And by the way, we also know very uneducated people who, are just my best friend. So we do a really crappy job of measuring socioeconomic status. By the way, if I'm offensive to anybody, accept my apology. But this is just, we do a bad job of measuring socioeconomic status. Unless we measure it perfectly, it opens the door for something called residual confounding, which means it's very much like cancer surgery. When you get some of the cancer, but not all of the cancer, I've adjusted for some of that confounding factor of socioeconomic status. I've done the best job I can, but there's still some stuff in there. And probably that's what happened to the hormone replacement is we just didn't measure socioeconomic status well enough. There are other theories why that came out that way too, but that's what I believe. Anyway, so who do you want in your trial? Clearly a balancing act. How weird are the weird patients? The results, can they be accepted for all subgroups, or is it really just one disease? Will subgroup analysis be required under any condition? You just have to use good judgment. Sorry. It's difficult to depend on subgroup analysis. My favorite subgroup analysis, when my wife is very much into women's health and women's issues, and you know, your NIH has very carefully made a statement about who, including women in studies. They say you must include an adequate number of women for a valid estimate. By the way, a very carefully worded sentence. Valid means unbiased. It doesn't mean precise or good or reliable. It just means that you get the right answer on average. Okay? It doesn't mean that you can tell if there's differences between men and women. It just means that whatever you estimate on average, if you did 10,000 studies and you averaged your male-female difference in your 10,000 studies, that answer would be correct. Okay? And I'll come back to subgroup analysis in a minute too. In fact, I'll come back to it very soon. Anyway, subgroup, it's common to approach special groups of people, subgroup analysis. Basically, in addition, men and women, is this treatment equally efficacious in men and women? In addition, it's natural and important clinical questions. There are subgroups in the population where the treatment was particularly efficacious, or there are places where it didn't work. These are natural questions, but require careful planning. You have to really plan these things out. And it sounds like I'm talking about confounding, and I thought confounding was not an issue, right? But that's not, this is effect modification, okay? Is the treatment effect, is it modified by what subgroup you're in? That's a different question than confounding. I wish I had more time to talk about that. So let me give you an example of subgroup analysis. And so basically, suppose I'm interested in and then I'll take a break after this, the relationship of diabetes and smoking to stroke among those with advanced atherosclerosis. And I used data from the ACAS study, that one that we talked about earlier. These are real data, real analysis. Okay? And it was motivated, basically this is a randomized clinical trial of surgical management for carotid atherosclerosis. In that group, there were 800 people measured mathematically, and those are the people I used. Of those, 79% were normal and 21% were diabetic. And this is an example in this context of an analysis of one arm of a clinical trial. It's not really a clinical trial, but I'm just using this as an example to show you the kind of mischief and trouble you can get into. Okay. So basically, one of my heroines is Elizabeth Barrett Connor. If you don't know Elizabeth Barrett Connor, go do an email, a Medline on her, and you'll be impressed. She's a cool woman. And way back in 1984, she wrote a paper about the interaction between cigarette smoking and diabetes. And in that paper, what she noted was basically that cigarette smoking is a lot worse for you if you're diabetic. You don't want to, it's bad for you anyway. But if you have a patient who's a diabetic smoker, they're in deep trouble. Okay, and that was the motivation for this subgroup analysis that I did in ACAS. And so basically, it's, my question is there increased risk for cigarette smokers? Is it bigger among diabetics and non-diabetics? So my hypothesis is in the time until stroke, will it differ between diabetics and non-diabetics? And will that be greater for smokers than non-smokers? And so what I did was just a survival analysis, straightforward survival analysis. This is real data now, real data. Okay. So here's my overall results from this. So this is looking at my diabetics and non-diabetics together. This is the Kaplan-Meier curve. I hope you're comfortable looking at these. And basically the hazard ratio is 1.43. So diabetes has a 43% increased risk of having a stroke, but it's non-significant. P equals 0.14 in these studies. So what do I say? 43% increased risk. But I'm not really interested in that. I'm interested in the effect modification by smoking. Okay, so what happens if I look at it for non-smokers? So here are the data for non-smokers. Okay, and basically you can see there's only an 18% risk for non-smokers. It's clearly non-significant. But among smokers, wow, look at that. I mean, I don't even need to do a statistical test. That's significant. Okay, and so I'll write a paper. There's a trend for diabetics to have higher stroke risk. It's primarily among smokers where the risk is nearly 3 times. Oops, I should have pointed that out. Let me back up. Look at this hazard ratio. Hazard ratio is nearly 3. That's amazing. diabetes is really bad for you if you're a smoker. Okay, so basically what do I do is it's primarily driven by smokers, nearly 3 times the risk. These findings confirm my previous literature establishing an interaction between diabetes and smoking. It confirms my belief that diabetes is important, and it underscores the importance of smoking cessation in diabetics. Who thinks I can get that published? I can get that published right now. Right now. So, so what really happened? What really happened in this? Okay. So to begin with, I lied. Okay. That is not at all what happened. Okay. That's not at all what happened. At first, I was really interested in hypertension when I was preparing for this lecture, not diabetes. And so overall, hypertension was non-significant in predicting stroke risk. I was really surprised. And I looked for findings in other subgroups. And in fact, smoking, did not make a difference. While I was at it, I also looked at sex, race, bruise, alcohol intake, height, weight, BMI, a ton of other subgroups. But when I started this, I wasn't really interested in smoking. I was just trying to find something that had effect modification. Okay. Nothing really excited me. I didn't want to write a paper about that stuff. That was not fun for me. Okay. And so it took me about 15 minutes to do that, by the way. The computers are the worst thing that ever happened to medical research. It's like giving chainsaws to children. I swear to God, you can do more damage. You can do more damage quicker with a computer than you can do good stuff. I mean, it's really bad. So, the next thing I did was analysis of cigarette smoking. Overall, it was non-significant. Nothing really excited me. I did the same 44 analyses there too. It took me another 15 minutes to do that. So now I've invested a whole 30 minutes into this paper. Okay. Finally, I turned to diabetes, and overall, it was non-significant, as we showed. I saw this association in smokers, and then I remembered Elizabeth's paper. At that point, I said, "Oh." Elizabeth Barrett kind of gave a talk about that one time, and I was in the audience with Elizabeth, and she said it was bad for you to be a diabetic smoker. That was not a priori in what I presented to you. That was a story. I found this, I remembered this paper after I was doing this. I ignored the significant other findings, by the way. Ever drinkers were also at higher risk. Okay. Previous contralateral endarterectomy. Bruise were at higher risk. Whites wasn't significant in blacks. History of hypertension was in effect not in the middle tertile of weight. I'd love to write a paper explaining why skinny people and fat people aren't at risk, but average weight people are. But the mechanisms can be hypothesized for some of these strokes. Basically, overall, I did more than 100 analyses. Okay? It took me about 40 minutes to do this. I really care about y'all. I really worked hard on this lecture. It took 40 minutes to do that. Okay. I reported only things that confirmed my biases and only things that was my sense of my literature. And was I cheating? And if so, how bad did I cheat? And the answer is I cheated bad. I mean, so what this graph shows is, and this is one of the ones I want you to keep in your mind. Keep in your mind. This is the number of comparisons I'm making here. And this is the probability that I find at least one significant finding. I find at least one significant finding. So by the time I get to 5 tests, I'm at a 20% chance of finding something. Okay? By the time I get to 30 tests, I'm at an 80% chance of finding at least one significant finding. 30 tests, by the way, is not a lot. If you think about these papers that have that forest plot at the end and shows all the different subgroups and everything, very frequently that 20 or 30 different factors are looked at. Okay. I flagrantly cheated. And by the way, intentionally flagrantly cheated. Okay. And the results remain very publishable, but likely worthless.
Guys, there is something which we would understand here, that is something called the probability. Okay, so if I ask you guys, what exactly do you understand from probability, beta? Ashita, Rinku, Kriti, Payal, anyone? You must have studied probability somewhere down the line.
Yes, sir.
So what do you think, beta? What is probability? Because beta, the reason I'm asking is probability is something which is going to be central for all of us for some reasons. Number one, आपने वो p वैल्यू हमेशा सुना है. आप रिसर्च पेपर लिखो, स्टैटिस्टिक्स करो, थीसिस सबमिट करो, कुछ भी करो, p वैल्यू आता है. तो p वैल्यू इज नथिंग बट प्रोबेबिलिटी वैल्यू, राइट? तो प्रोबेबिलिटी p या प्रोबेबिलिटी पॉइंट ऑफ व्यू क्या है बेटा? व्हाट एग्जैक्टली इज प्रोबेबिलिटी? आपने एक एक्सपेरिमेंट भी सुना होगा एटलीस्ट स्टार्टिंग में बेटा, टॉसिंग ऑफ द कॉइन. ओके,
Yes.
दैट इज द कॉमनेस्ट वन. तो टॉसिंग ऑफ द कॉइन, बट आपने कॉइन टॉस किया, तो व्हाट इज द प्रोबेबिलिटी ऑफ अ हेड और अ टेल?
So either it will be head or it will be a tail.
हाँ, so that's 50-50 sheer chances. Okay.
हाँ.
Okay. Now if I ask you, suppose you have a dice. Dice आपको मालूम है बेटा, वो 6 नंबर्स लिखे रहते हैं, 1 to 6, 6 फेजेस वाला क्यूब टाइप का डाइस. ओके, अब आपने डाइस फेंका तो आउटकम, जैसे टॉसिंग द कॉइन का 2 ही आउटकम है. डाइस का आउटकम कितना आता है बेटा? कितना आएगा आउटकम?
6 आउटकम्स है ना, 1 to 6 रहता है.
कितना बेटा?
1 to 6 है ना सर, so 6.
नहीं 96 नहीं है बेटा. बट ओके, you're thinking करेक्ट. तो बेटा वो आप जब डाइस की बात करोगे तो व्हाट वी बेसिकली डू इज ना, हम लोग बोलते हैं प्रोबेबिलिटी अगर निकालना हो कि आउटकम्स कितने हैं, तो यू वुड लुक इनटू फैक्टोरियल 6. देयर इज अ वर्ड कॉल्ड फैक्टोरियल 6 बेटा. तो जब हम लोग बोलते हैं फैक्टोरियल 6, उसका मतलब होता है 6 into 5 into 4 into 3 into 2 into 1, right? So when you say 6 into 5 into 3 into 2 into 1, that is the probability of how it works. So that gives you an idea about 726 outcomes. Okay, तो बहुत ज़्यादा आउटकम्स मिलता है. यही चीज़ बेटा आपका फंडामेंटली रियल टर्म बेसिस पे भी रहता है. जैसे फॉर एग्जांपल आपने ये कहावत सुना होगा कहीं ना कहीं कि भाई अपने जैसा 7 बंदा, और मतलब कुल मिला के 7 बंदे जो आपके जैसे जेनेटिक मेकअप वाले हैं. ओके, जीन्स. तो आप सोचते हो यार, हाँ 7 मेरे जैसे होंगे बेटा. अगर हम लोग मान लेते हैं कि जेनेटिक मेकअप आपका एकदम ही सेम है, तो रिपीट्स हो सकता है. किस बेसिस पे निकालोगे? तो हम लोगों को पता चला कि जीन्स, हम लोग ये पहले से बोलते आ रहे हैं, लेकिन जीन्स का जब अपना स्टडी हुआ, ह्यूमन जीनोम प्रोजेक्ट जो 1990 से स्टार्ट हुआ, 2003 तक गया, यानी 10 साल लगा अप्रॉक्सीमेटली, उसमें पता चला कि अपने पास 30,000 जीन्स है. तो फैक्टोरियल 30,000 is the one which will be important beta. Factorial 30,000. Okay. Hello, you guys there?
Yes sir.
Okay बेटा. तो फैक्टोरियल 30,000 निकलेगा तो इट कम्स इन बिलियंस. तो 7 बिलियन के आसपास आता है बेटा. तो इसका मतलब 7 बिलियन या ऐसा बिलियंस में जब काउंट आता है, तो 1 बिलियन के आसपास इज द वन विच द टोटल नंबर ऑफ पॉसिबिलिटीज विच आर बीइंग देयर. तो 1 बिलियन में 1 बिलियन एंड सम 93 मिलियन एंड 12,000 समथिंग इट कम्स डाउन टू. तो जब ये वैल्यू आता है तो अपन ने कैसे किया, 30,000 into 29,999 into 29,998 till it comes down to 1. तो जो वैल्यू निकला दैट इज द वैल्यू विच यू आर टॉकिंग अबाउट. तो वैसा प्रोबेबिलिटी देखा जाए तो 1 बिलियन समथिंग एंड सम नंबर्स में यू वुड हैव 1 रिपीट चांस ऑफ द एंटायर जीनोमिक सीक्वेंस जैसा है. तो अपना अर्थ का पॉपुलेशन कितना है? 7 बिलियन. तो 7 बिलियन है तो मतलब 7 बार सेम रिपीट्स हो सकता है. एंड दैट इज द रीजन व्हाई यू से देयर आर पॉसिबिलिटी ऑफ 7 पीपल इन द वर्ल्ड हु विल हैव सेम जेनेटिक मेकअप. बट जेनेटिक मेकअप का मतलब ये नहीं कि वो आपके क्लोन्स है. जेनेटिक मेकअप इज अफेक्टेड बाय एनवायरनमेंट. तो हो सकता है वो एक निग्रो हो सकता है एक वो अमेरिकन हो सकता है वो कॉकेशियन हो सकता है एक चाइनीज हो, हैविंग द सेम जेनेटिक मेकअप, एंड हो सकता है एक इंडियन हो. So that's the way how you look into it. So probability is used out in genetics, probability is used out in clinical trials, probability is used out in real term way of finding out the exact details. Now that's what is probability, and that is being used across to find out how much is the chance that you are playing around with the data so that the data is being manipulated. If it is less than 5%, then it is fine. That's why बेटा हम लोग लिखते हैं p value greater than equal to 0.05, तो accepted rate रहता है. Is it clear बेटा?
Yes, sir.
Okay बेटा. So we stop here for the day today because this is the probability part which we wanted to cover up. Next is the subgroup analysis which will be continuing beta. So we'll continue with the subgroup analysis next time. So till that time we meet till on Monday. I wish you a goodbye and good day, and thank you so much to four of you, Ashita, Rinku, Preeti and Payal, to have sat across this entire lecture. Thank you so much beta. Have a nice weekend. Bye
Thank you.
guys.
Yes.
Bye.